Hello everyone, and welcome to this second webinar on digital ecosystems management. Just as in the first webinar, we have two presenters, and you have the possibility to write your questions in the Q&A window, which we then will try to bring forward in the Q&A sessions after each presentation. Our two presenters today are Erik Ranschaert and Vincent Dupont. And Erik Ranschaert, he is working as a radiologist and digital doctor at the ETZ hospital in Tilburg, the Netherlands. He is also a professor at the University of Ghent. His research is focusing on artificial intelligence for radiology, and he is recognized as a leading scholar in the field. He is also a frequently invited speaker at international meetings and a co-editor of the first book about artificial intelligence in radiology. Erik is practicing digital ecosystem management in the healthcare industry. He has a refreshing view on the industry and how it should evolve, and I'm very happy that he wants to share that view with us today. It's Thursday and Erik is working at the hospital. He pre-recorded his presentation, but he promised me to be online for the Q&A session. Let's have a look at the pre-recorded presentation.
Hello everybody, I'm Erik Ranschaert, radiologist from Tilburg in the Netherlands. So today we will talk about how disruptive AI can be for radiology or healthcare. First of all, I would like to give you a good idea of what radiologists are currently doing. Radiologists are active in imaging, and this specialty is subject to technology and data because we are providing a lot of images, and all this image information is digital. As you can see here, we are not only reporting images, but we are also doing interventions such as, for example, interventional angiography. We also do ultrasound with patients, etc. So we are also active in treating patients. We do work with many different modalities such as ultrasound, CTs, MRI, and plain radiography. But all data is digital, and we also have a standard format in these digital data, and that's DICOM. This way we can also effectively or efficiently store and share data, and usually we use a PAC system for doing that. And we also follow international standards to connect systems with each other so that they can talk with each other. And for that reason, we are following the IHE standards. Because all this information is digital, we can also do teleradiology or telemedicine by distributing or making these images accessible elsewhere. Now, artificial intelligence is progressively being implemented in clinical practice, and especially in specialties that are quite data intensive and producing medical images such as radiology, pathology, ophthalmology, and dermatology. Radiology, however, is on the forefront. Most applications that are being developed now can be used for image analysis. And so this is the area where we are most prominent, let's say. And these algorithms, they can be integrated in the radiology workflow for a variety of tasks, both for imaging and non-imaging, and I will explain you how. But the potential for AI in radiology appears endless, and in the same time, the field is still in its early stage. So this is a graphic display of the radiology workflow. So usually it starts with a patient in the waiting room, and the patient often needs to be prepared. And this is where the radiographer is usually active. And then the examination is prepared. A protocol has to be selected on how to perform the scan, for example, and then the examination is executed. And this is all done by the radiographer, and in several cases, radiologists are also involved, but that's in a minority. And then after the examination is performed, the quality needs to be assessed and the images need to be post-processed before they are distributed and presented for analysis by the radiologist. So radiologist is sitting here in his workstation, and he is doing the image analysis. For that purpose, he can also use AI. And then, of course, the results, they have to be communicated to the referring physician. This is also a nice drawing showing you what the current possibilities of AI are. So, as I explained, first of all, the examination needs to be performed, and then there's some post-processing that is also performed before the images are being distributed or sent to the workstation. And so the images are produced, and then some image-based tasks can be performed by artificial intelligence. And the most frequent ones are these. So detection of abnormalities, this could be, for example, in the lungs, could be lung nodules, that could be breast cancer, that could be a tumor in the brains. And then these lesions, they can also be characterized. For example, a lesion can be benign or malignant. And this is also something where AI can be useful. And of course, when patients are being treated for cancer, they need to be followed up by repeated examinations. So the lesions, how they are evolving under therapy, this evaluation can also be made with the help of artificial intelligence. Now, this is an example of how these tools look like. So this is an image of a CT scan in the chest through the lungs, and you can see that the algorithm here automatically detected a nodule, which is automatically measured. And as you can see here in this display, there's several lesions that have been detected by the software. And this information, these measurements are made automatically, and then this information is also automatically included in the report. So the report here says, even provides some information. It provides an advice on how to treat the patient, because the algorithm was able to stage the cancer. Now, as I said, we can use AI for and making an image analysis, but we can also use it for other applications which are not image related. And for example, AI can also be implemented for scheduling patients. It can also be used for selecting the right image protocol, or for preparing to see if the patient is ready for the examination. We can also use it to post-process the images automatically, to, let's say, display them automatically in the right order for the radiologist. And then, of course, this is a major task at this moment. So AI is being used to interpret the images and for decision making. And then we can also use AI to communicate the results, for example, by automatically providing different types of reports, and even reports that can be read by patients. But this is the major application at this moment, because most AI solutions are based on deep learning, which is a specific type of artificial intelligence that can be applied especially for images. Now, this is how the process usually looks like. So the scan is being made, and then the images are being sent to the PACS system and even to the electronic patient record. And then these images, before they are analyzed or to be analyzed, they are sent to a cloud-based server, and this cloud-based server is sending back the results to the PACS and to the electronic patient record. So, as I said already, most AI use cases, they will assist radiologists in analyzing the images and adding relevant findings to the report. So, even in some cases, AI solutions might bypass the radiologist. For example, for when the AI solutions are being applied for automated analysis of emergency examinations, these reports can go automatically to the referring physician even before the results are validated by the radiologist. And then I'm thinking about automated detection of fractures, for example. There's already tools available to do this, or this could also be the case for a patient with a cerebral infarction or a bleeding, so that the images are automatically sent to the neurologist. For screening purposes, this could also be the case. As you probably know, screening always takes place in a large volume of patients. This is nationwide, and so a lot of examinations need to be analyzed. For that purpose, the first read could also be done by artificial intelligence, and only in the difficult cases, the radiologist could perform a second read. This is not being applied at this moment. This is not being applied yet, but nowadays they are seriously thinking about implementing AI for screening purposes. But what we can see is that adoption at this moment is relatively slow, and it's very difficult to predict the future at this time. So we're not sure yet. We have to make some, let's say, prognostics about this. So at this moment, the adoption is relatively slow. So what are the main reasons for that? At this moment, not everybody is on board yet, and that's something we should do to get everybody on board with the nose in the same directions. Certainly, it's important that clinicians are eager to use it, and this is something what's still missing. Radiologists are now in the front line of using AI solutions, but clinicians are lagging behind. So this is what we're missing at this moment. Implementing AI solutions is also a resource-intensive project. And it's still not very clear how we can obtain a return on investment. So this is not easy either. There's also a technical barrier because these solutions, they have to be seamlessly integrated in the workflow. Radiologists don't want to click any additional button or perform any additional mouse click. This is just simply too much. And this is also something that needs to be taken care of. And of course, at this moment, there's a little bit lack of prospective evidence because these solutions have been created and they are now coming in the market, but we still don't have enough evidence about what the outcomes will be and what the effect is on patient treatments and patient care. And of course, we also have to think about the fact that the pandemic is slowing down the strategic planning and the investments also in AI solutions. Now, yes, we can speak about the possibility of a digital disruption in the future. So AI will certainly modify the radiology workflow and the tasks of the radiologists. And even certain tasks of radiologists, they could be outsourced to external parties in a later stage. For example, to parties that can work 24/7 at a lower price by using AI. This could also happen under pressure of health insurers or even government if they say, okay, we have to reduce the costs, we have to outsource some tasks elsewhere. And for example, as I said already, this could be one of the solutions to reduce the costs involved in nationwide screening, such as breast cancer and even lung cancer. The question is, of course, will this lead to further consolidation of private practices? Will this be a driving factor to unify or to gather all these individual practices? Will this lead to cross-hospital services? So will services be provided or will the tools be made available cross-hospitals? Or will the workflows be divided over hospitals? That might be also an evolution of large-scale implementation of AI. It could also be a way to democratize the access to AI. And then another question is if cloud service providers, and this is the place where most AI solutions are being performed, well, will these cloud service providers, it's possible that they become major healthcare providers as well, that they think about developing this kind of services too. And then the question is also, will non-radiologists, might non-radiologists take over image analysis with the assistance of AI? That's another relevant question we should ask ourselves. Now, what are the challenges and opportunities for implementing AI? First of all, there needs to be more clinical measurement of clinical efficacy, and we also need clinical validation. So actually what we need is proof that the underlying technology works in a safe way. What we have to do is perform more prospective studies and obtain evidence for that. And of course, we also have to obtain some guidance or create guidance on performing such studies. How should we measure this? How should we evaluate this? Then, of course, the health economics are also an essential challenge. We have to demonstrate that using such tools can give a return on investment. And of course, for example, at this moment, it's not always clear if the department that is purchasing AI will be the beneficiary or the sole beneficiary in the downstream cost savings that are being made. For example, if hospitals want to implement an AI solution for automated detection of fractures, this is not only an advantage for the radiologists, but also for the emergency physicians, of course, because the results will be immediately available. So there is a need for wider conversation on the broad funding opportunities for AI solutions. And of course, a proper economics analysis is needed. And it's simply too early for that. Now, the IT infrastructure, of course, is also an important challenge and issue. So can we plug in new AI solutions in an outdated IT infrastructure? This is a problem. And in this discussion, we also have to involve all stakeholders taking care of data management, and they all have to be aligned to achieve something. So how can we overcome these challenges? Well, first of all, as I said already, we need evidence-based experience and trust. And we also have to make partnerships and collaboration. And furthermore, I think it's also essential that we accept cloud-based solutions to work more efficiently and to allow cost savings. And we will also have to involve all stakeholders. And of course, this is quite essential. We have to obtain access to data and resources. I will explain this a bit further. So first of all, the alignment of stakeholders is very crucial. So we do have the radiology department, but in the data management, there's also other stakeholders involved, such as the ICT department or the PACS management. And we also have the data warehouse in the hospital. We have the clinical physicists that are taking care of the quality and safety of image distribution and processing, etc. We have the clinicians that have to use this information and that have to add the right information. We have the board of directors that need to make investment decisions. We, of course, have the data privacy officer that will have to develop a policy regarding the digital data management. And we have the purchasing department, and also we have the vendors of AI systems, the OEM vendors of the original equipment manufacturers, and then we have the PACS vendors as well. So all these parties are involved in the implementation of AI, and they have to be aligned. Actually, what we need is an orchestra of stakeholders, and the key, of course, are the radiologists, but we should not forget the importance of the clinicians in the orchestra. And then, of course, the hospital managers, they also have to accept the fact that we need innovations, that we have to innovate. And yes, a good orchestra with brilliant players, which clinicians certainly are, we do need a good conductor. We need coordination. And the conductor, that needs to be a local champion that is 100% dedicated in, completing this challenge. Now, we have to build a culture of change. And to do that, what we need is leadership teams. Leadership teams, they have to be aligned and committed for change, and they have to give clear directions, and they have to have clear expectations, and everyone needs to be in the same direction. Of course, the chief financial officers, they also have to show that investing makes sense. So they have to prove that there is some return on investment. The clinicians, they also have to drive forward the usage of AI. They have to ask for it. They have to see the value of it. And the tech teams, the existing tech teams in the hospitals, well, probably they will have to change their skill sets, and which will be needed to maintain the infrastructure. And this will certainly evolve in the coming 5 years. And the patients, they also have to be involved. We have to ensure that patients are at the heart of conversation. They have to be informed about what's happening with the data and what the AI is doing with them. And of course, it's quite logical that patients will say no decisions about me without me. We have to take that into account. So there needs to be a proper consent and support of the population. The partnerships and collaboration, yes, we from the beginning, from the development phase, we have to there has to be a partnership between clinicians and developers. They have to understand each other. Developers have to understand the clinical use cases and the situations for which AI could be useful. So they have to work as a team. They have to speak each other's language. What we also should promote in the hospitals is innovation hubs. We have to promote and facilitate them. And of course, AI should not be seen as an elite tool for only academic institutions. Also, the general hospitals, they have to be involved. They need to adopt AI solutions because they have to be involved in the validation by conducting pilots, for example. So general hospitals, they could be seen as ambassadors, and they should be involved in providing prospective studies. And what we especially need is a close strategic alignment between startups, healthcare providers, cloud providers, manufacturers, and they all together have to find the best route of deployment. So will it be in the modalities itself? Will it be in the cloud? Will it be in the PACS, in the electronic patient record, etc.? These are things that need to be decided upon collectively. So what are the elements for a cohesive ecosystem? Where, first of all, we have to answer the question, where can we get the money? Who will invest? And what hospitals will purchase for what reasons? Where can we get sufficient data? And who will provide access to those data for what price? What's the use of providing access to those data? And how can we do it securely and safely? Targets need to be aligned, and there have to be achievable timescales to get AI from the laboratory to the clinical bench, because there's a lot of algorithms that still need to be trained and developed, and it takes a lot of time before you can bring them from laboratory to the bedside deployment. And then, of course, this will be quite similar to what's happening in pharmacy already. So there's a lot of processes that need to be completed, such as the evaluation of the clinical validity, the ethical issues need to be solved, there's health economics, there's safety issues. So there's a lot of parallels. And I think AI will probably not be quicker than the development of any medication. So we have to think about these partnerships and collaborations. So we have to bring all stakeholders together, and this will accelerate the pace of AI adoption. And of course, medical advisory boards also play a significant role in this. So my advice to hospital leaders and clinicians is the following. First, don't just think clinical. You best start with a simple process that can be facilitated from the operational workflow. So this is called the low-hanging fruit, not too complicated. And start with a problem, identify a problem, identify a bottleneck, and work backward to find the right tools capable of improving patient experience or reducing the workloads and improving the clinical outcomes. Integration with the existing infrastructure and the workflow is really important. So you have to think well about how to integrate in the current workflow. And this should be really seamless. So that's key to adoption of AI. And don't always rush into these things. Take your time. Due diligence needs to be performed. Collaborate with vendors. Take it slowly, deliberately, and carefully. Think about the underlying core infrastructure. Don't think only about the V8 engine that will be in the car. Think about maybe upgrading your chassis first. And then consider a wider infrastructure. Hospitals should stop functioning as silos. Data, they flow in a wider spectrum, so we should move to cloud-based solutions or make this change. And it's crucial to have a 100% dedicated local champion, as I said already. And of course, this is important. We have to invest now in training the workforce on AI adoption and acceptance. And we also have to train medical students for this so that this can be successful. So my conclusion is the radiology profession, it will change, but we will have to accept the change. It's fun and it will be fun. Radiologists, they will remain involved in making diagnosis, in doing risk scoring, following up patients, and providing clinical decision support by doing the analysis correctly. And AI is going to make the profession much better. I thank you very much for your attention.
Erik, you're there, but you have to unmute yourself. Yeah. Thank you for being here, and thank you for this beautiful and very inspirational presentation. It was pre-recorded, so thank you for being here for the Q&A. Let me just start with the first question, and then I let Ijeoma take questions from the Q&A. Hi, Ijeoma. So the first question I have, and it's the only one I'm going to ask you, is you emphasize a lot the role, let's say, of the workflow or the changes in the workflow of the radiologist, but also, and as important, the involvement of the other clinicians. So you emphasize a lot the role, let's say, not of the technology itself, but the role of how the use cases and what you have to do and what you have to change within the hospitals. So what is then your advice or your, let's say, the implications for vendors, right, of technology? Could be cloud service providers, could be companies, big companies like Siemens and Philips that deliver hardware and other equipment. So what, because we have in management and in ecosystem building or ecosystem management, we have a lot of this kind of provider driven and provider orchestrated ecosystems. This would be more like the demand side, or let's say the downstream partners, here in this case the hospitals, that drive the change. What is your view on that?
Well, yeah, actually, my view is that, of course, the AI should not be the goal on itself. So we have to look at the improvements that we can make. This is actually what I also did, for example, in the Netherlands Cancer Institute, where I have to find ways to, let's say, simplify or reduce the workload. And then you have to go and see what are the bottlenecks in the workflow. Is it the patient scheduling that's taking too long? Is it the workload of the radiologist, the examination analysis that takes too long? What are the reasons for these delays in workflow and scheduling, etc.? And then you have to once you have identified these bottlenecks, these hurdles, then you can start thinking about what could be a possible solution, and where could maybe AI help us. And in some cases, in several cases, there will be an existing application. Again, an example from the Netherlands Cancer Institute. There's a lot of patients that need to be followed up for cancer, and they get repeated scans to see if the lesions improve or, let's say, if they react to the treatment. All these measurements have to be made, but in some patients, well, there were too many patients, so there was a huge backlog, and some patients developed pulmonary emboli, and that was risky. So you cannot leave these examinations unreported, because then there's a patient at risk. So what I did is implement an AI solution to automatically detect the pulmonary emboli, so that these examinations could be prioritized, so that radiologists could read first those examinations where the AI had the suspicion of a lung embolus. Yeah. And that's one solution. Another solution, for example, is the fact that some examinations might take too long and could be too cumbersome for radiologists to deal with. One of those examinations, for example, is a MRI scan of the brain to see if there's any brain metastasis. That's a very, very tedious job, because you have to find all these small nodules, and this is actually very important for patients. So there was no solution for that. So I said, okay, let's start developing an algorithm for doing that. So what I want to say is that you might find existing solutions, but in some cases you will have to find solutions yourself or create them. So it will always be a combination of implementing existing solutions, and if they don't exist, hospitals will have to make it themselves, and they have to make partnerships. That's what I also stressed in my presentation. You need to create partnerships. Some big institutions like MGH or in Stanford, they have these specific centers where they do this. They work in close collaboration with funding as well from the industry to develop specific tools that they could need. And maybe those tools could also be implemented in other hospitals. So you have a business case there. If you develop these tools yourself with your own data, you could also try to commercialize the tools that you create. So that's a new kind of business case for the hospitals. And yeah, that's also part of the ecosystem, of course.
Very good, thank you. Ijeoma, do you have questions from the Q&A?
Thank you, Professor Wim. Thank you, Erik. We have a couple of questions for you. The first is from Stijn Kelchtermans. His question is, where do the training sets of image interpretation come from? Are AI systems used in Europe trained on data from European patients? Does this matter in a field like radiology? Are these data sets sufficiently large?
Yes, well, good questions. First of all, data sets, difficult to obtain. That's one of the main issues. There's some public data sets available, but usually the number of data they need to develop a good algorithm is insufficient. First of all, the number of data to develop tools based on deep learning, the data has to be very large. The larger, the better. But it's not only the number that counts, it's also the quality of the data. So in most algorithms that are being trained at this moment, the annotations still need to be made manually. So this is really important. And a quality management in manual annotation of data is significant. There's one saying everybody knows: garbage in is garbage out. So if you use bad data, you will get a bad algorithm. And that's the main question one should ask. If I buy an algorithm, or if I want to use an existing algorithm, where has it been trained upon? What is the quality of the data? How many data have been used? And it's not always the matter what the geographical origin of these data is. Of course, for specific application that might be biased by some abnormalities that occur in specific areas of the world and others don't. Well, yes, in those cases, the geographical origin of the data could be relevant, but that's not generalizable. I mean, you have to look mainly at the quality of the data and the number of data that the algorithm was trained with.
Okay. We have another one from Anne-Lene de Koning. Her question is, elements for cohesive ecosystems. How could you include the work on developing and nurturing a culture for change within the hospitals?
Yes, also very good question. There's a lot of effort that has to be done to install a change management. And this is also why I stress the importance of the team building. You really also need some kind of, and this is what's happening in the Netherlands, for example, in several hospitals. What is happening is that their hospitals are creating, first of all, they have a local champion, which might be official or not. And then they establish some kind of a AI workforce or a team that takes care of centralizing all the initiatives that are being taken in several departments. So this needs to be organized one way or another, because otherwise you will not find sufficient support, funding, etc. And then, of course, you also have to think about how will this affect the treatment, the reaction of, first of all, the radiologists working with it, and secondly, how will patients and users react on us radiologists using these tools? So there's still a lot of work that needs to be done, and we will have to investigate this by doing research. We are trying to do that in our hospital as well, but we are still in the early phase. So there's still a lot of things that need to be examined.
Okay, another one from Jean Cheng. His question is, coming from a pharmaceutical industry, he wants to know if including regulatory and payer partners could provide assurance for profits and regulatory stability in this technology.
And if I could add to that, Erik, there's also a similar question from Rudy Martens, who is asking why you don't include, let's say, the patients in themselves or for the government regulators and so on. So why not shaping, or why not designing, let's say, the ecosystem wider than what you have done so far?
So actually what you are suggesting, if I understand well, is some kind of crowdsourcing where patient could also make their data available or accessible. Is that the main idea? Yes.
But there's also a question about, so should you extend it to regulators, to governments? So who should be in that ecosystem? Yes. Because you have been focusing on the hospitals, you have been focusing on the vendors.
Yes, I agree. Yes, we do have some regulatory hurdles that have to be made, taken. And this is also the case in the Netherlands. And we can see that, especially in Europe, we're pretty strict on that. There's other countries where there's a lot less, let's say, regulatory inhibitors, making these data accessible. And yes, we have to think about this. There should be, we have to make the politicians aware of the importance of sharing data for research purposes. I'm not saying that hospitals have to share all the data to commercial parties, but we have to promote research in this area, and we have to promote the development of tools. And yes, the regulatory measures will have to adapt. And this is, of course, something that is evolving. So at the time when the GDPR was constructed, we were not in this stage yet. So I think the existing regulations have to be adapted. There needs to be some dynamic element in these regulations as well. That is really relevant. Yeah.
Facilitating data sharing for research purposes is certainly something that we have to look at from a regulatory point of view. Okay.
That's correct.
Ijeoma, back to you.
All right, thank you. A question from Peter Ross. He has really enjoyed your realistic overview of AI in radiology, and he has 3 questions. The first one being, how do you see AI being implemented in line with European Medical Device Regulation, MDR, which sets a lot of requirements for medical software developers? The second question, would language barrier limit AI development and uptake in different countries? The third question, how to handle versioning of AI? It is obvious that AI will have new releases. Could this lead to different guidelines and questions about the reliability of previous versions?
That's yes, very relevant questions, but not easy to answer. So yes, of course, the MDR is relevant. It's going to be applied in May, I think, this year, because it has been postponed due to the pandemic. But yes, this will affect the way applications are being certified. So we have in Europe the CE mark, and at this moment, most applications are class 1, but probably most applications will have to be moved to class 2A or class 2B. It all depends on the risk they have or the impact they have on the treatment of the patient. And the risk is higher when errors are being made that affect this treatment. So for example, if this could result in surgery of the patient or even death of the patient. So this needs to be involved for every application. And second consequence of this MDR is that AI tools will have to be followed up over time. So the evaluation of the functioning, of the accuracy of the algorithms will become a continuum, which is really relevant, I think, and is a good thing, because applications will become obsolete, for example, or outdated when new equipment is being bought, when other data are being used. So hospitals do change their equipment, they do change the scanners that they're using, so the data will be changing and the algorithm might not be accurate with using such data. So this needs to be followed over time, and hospitals will have to develop procedures to do that. And I think personally that we will even see development of new kinds of services and teams within hospitals to do this, to ensure that the MDR can be followed. That, and also the companies themselves, of course, they will have to adhere to the MDR regulations, so they will have to take measures. Of course, they do have some time. I mean, some applications still are valid until, let's say, 2024. But in the meantime, in the coming years, they will have to adapt their management in let's say, implying these tools. And then I think there was a third question. I forgot what that was.
Okay, the third question was how to handle versioning of AI. It is obvious that AI will have new releases.
Yes.
This could lead to different guidelines and questions about reliability of previous versions of versions.
Yes, of course, every application will have to, let's say, go through the same procedures again to be implemented. But I know that also in that area, some insights are changing. For example, the FDA will apply some kind of a dynamic FDA certification system, so that the applications can automatically obtain certification if they are updated. But of course, there will have to be a management implied by which the applications are updated regularly.
Ijeoma, I think we have the time for one more last question. So if you have a nice question for Erik just to finish it, that will be great, because I think you have to go back to your hospital job, correct?
That's fine. I do have some time. That's okay. Don't worry.
Okay. I think everyone has enjoyed your presentation, so I'll just give you this last one. I hope it's okay. It's from Rudy Martins. He says, an ecosystem can be seen also a big brother. Government, patients. Do you think that patients get involved in the current evolution? Patients become more educated and more communicative. Can AI directly translate the AI observations in an understandable language for patients so that specialists do not have to explain, or only partly themselves, the results of the diagnosis therapy? Any evidence on that already?
No, it's too early for that, but I do agree that patients need to be informed. That's also what I said in my presentation. I think they have to be at the heart of the discussion, so they should be aware of what's going on. Actually, to be honest, I think patients, there might be a mixed feeling, but patients should be informed about how the AI is being used in the hospital and for what reasons. It's the same as, for example, you would take an airplane and suddenly you would hear that there's no pilot and it's completely flying on its own. I mean, I think you would not be happy with that. So that's the same for patients going to a hospital. I mean, if they would know that there's no doctor behind it and that just a machine is taking a decision, well, nobody would be happy. So I think that's the same everywhere. Patients need to be informed about what's being done. I know from applications that we have deployed in our hospital that we published this in the paper, in the local paper, and people, they just called me and they said, oh, wow, are you using AI? That's great. How are you doing this? And so you have to, let's say, let the outside world know that you are doing it, but just in the right way. And yes, so patients do need to be involved in that.
Thank you.
Good, thank you, Erik. I know you have a busy afternoon, so thank you for making time. We have many, many more questions, so we're going to try to capture them and see if we can make a summary of that. Yeah. Thank you very much for your time. It was very inspirational. I think everybody liked your presentation. Sorry for the technical problems. That's only my mistake, so I apologize for that. But I'll let you go. Thank you again, and hopefully we see each other another time.
Thank you, Wim, for having organized this. And of course, if you have more questions, please send them to me, and people can always contact me. They will find me on LinkedIn or they can mail me. So if they want ask me any questions, so please go ahead.
That's good. And Ijeoma will probably assemble the questions for you too, so that we can get something out of that. Thank you very much. Have a good time and have a lovely afternoon.
Thank you very much.
Bye-bye.
Bye.